Okay, our next speaker is Dr. Yulia Young, who will talk about provider discontinuity and quality of care for nursing home residents.
Okay. Hello, I'm Hyunkyung Yulia Yoon. I'm a PhD student at Brown School of Public Health, and today I'm going to present about the association between provider discontinuity and quality of care for nursing home residents. First, I want to acknowledge my mentors and co-authors, Dr. Morgan Rue, Dr. Hyunkyung from Cornell University. Ambulatory care sensitive conditions are present in nearly half of all hospitalizations and emergency department visits among nursing home residents. Nursing home residents are medically complex and require highly coordinated care, and physicians and nurse practitioners, physician assistants, so I'm going to call them advanced practitioners, they play a key role in their care in nursing home setting. And nursing home residents often experience disruptions in care, leading to the receipt of care from multiple clinicians. So for example, once they admitted to nursing home, residents may keep their community primary care providers even in their nursing homes, or they may be assigned to a new clinicians who are working in that nursing home. And evidence suggests that access to high quality primary care may reduce hospitalizations and ED visits among older adults in the community. And discontinuity in primary care clinicians has been associated with worse patient outcomes for them, and also higher healthcare costs for them. However, unlike the relatively rich evidence in other settings other than nursing homes, little is known about the role of clinician discontinuity and the outcomes of nursing home residents. So our study aimed to examine the association between discontinuity in care provided to nursing home residents by physicians and advanced practitioners, and quality outcomes among nursing home residents. And we also examined whether discontinuity in clinicians is associated with total healthcare costs for them. So let me go over the methods quickly. We used the national 20% random sample of Medicare fee-for-service beneficiaries who became long-stay residents between 2012 to 2019. And we used the Medicare claims data and enrollment file and other clinician and facility level data as listed here. And our target population included Medicare fee-for-service beneficiaries who were aged 65 or older and who became long-stay residents. And long-stay residents were those who stayed or in the same facility for 100 days or longer without 10 consecutive days outside the facility. We limited our target population to those who were continuously enrolled in Part A and B. We excluded residents who were residing in the hospital-based nursing homes because their characteristics or their practice patterns may be different from other general freestanding nursing homes. We excluded residents who did not have any evaluation and management claims, E&M claims, after the first year of their stay because we're not able to attribute those residents to the clinicians in this period, meaning that they didn't have a chance to experience the discontinuity of care, which was expressed and defined as a change in the attributed clinician based on our attribution logic for the residents to the clinicians, which I'm going to explain in a minute. And so these remaining residents were attributed to clinicians based on the number of E&M claims in the nursing homes in a given year. So in case of a tie in terms of the number of E&M claims, we used a random determination. And clinicians were limited to physicians, nurse practitioners, physician assistants, and the physicians included generalists, including general medicine, internal medicine, family medicine, and physical medicine, and rehabilitation doctors, and geriatricians. We also limited our clinicians to those who had at least 20 claims in a given year. And the reason why we excluded other specialists was because specialist providers other than those specialties that I included because the changes to or from those specialties would imply different circumstances regarding residents' health status or the purpose of care from the rest of the residents may have conditions. For example, those residents may have conditions that require intervention from that specific specialist, and it may introduce confounding bias. So that was the reason of the exclusion. And the determinant of interest was a discontinuity of care. So we created a binary indicator reflecting whether there was a change in the attributed primary clinician from the first year to the following year of residence stay. And this was the reason why we had to exclude residents who had records for less than 2 calendar years. Outcome measures were ACS hospitalizations and ED visits related to ACS reasons, because these events are common among nursing home residents and they're largely preventable with appropriate ambulatory care. We also looked at the quarterly total healthcare costs, and healthcare costs were Medicare expenditures, including inpatient, outpatient, professional, and other services. And we included a rich set of covariates, including residents' demographic characteristics, their Medicare status indicators, such as dual eligibility or entitlement due to disability. We also included their health status indicators, such as baseline antipsychotic use, ADL scores, cognitive function scale, in addition to 6 to 5 chronic conditions. We also included clinician level and facility level characteristics as listed here. And for the analysis, residents were observed up to 2 years to isolate the influence of the length of stay from the likelihood of experiencing discontinuity of care, which was expressed as a change in the attributed clinician, and also from the resident's health status. We made just a comparison using the linear regression model with the nursing home and year-quarter fixed effects. The comparison group included residents in the same facility, but who did not experience the change in the attributed clinician, and standard errors were adjusted for the clustering at the nursing home level. We also conducted 4 types of sensitivity checks. First, we excluded the smallest 20% of nursing homes based on the number of beds, because these nursing homes were small, so they have fewer clinicians, and the residents in those facilities may be less likely to experience the change in the providers. We also limited the residents to those with low baseline ADL and also high baseline ADL scores. We also did a sensitivity check using the composite outcome of ACS hospitalization and death to account for the competing risk of death. So let me share the findings. So our sample included 280,831 long-stay nursing home residents. And the baseline characteristics were identified by provider change versus no provider change group by looking at the first year-quarter records of them. And as you can see here, demographic characteristics between those two groups were very similar. P-values were mostly significant due to the large sample size, but the differences were clinically not meaningful. And also, there is much differences in the presence of chronic conditions, except for a small difference in the depressive disorder. Residents in the provider change group were less likely to have MDs as their attributed clinicians at the baseline, and those were more likely to reside in the nursing homes that were for-profit and part of a multi-facility chain. And these are the results from our main analysis. Residents who experienced the provider change in their following year, in the second year, were 14.2% more likely to experience ACS hospitalizations and 11.5% more likely to experience ACS ED visits. In addition, and also they shared a higher total quarterly healthcare cost by $609 compared to those who did not experience the provider change in their second year. The results from the three sensitivity analysis were largely consistent with the results from the main analysis, except for the one that used the composite outcome of ACS hospitalization and death, which was statistically insignificant. So we found that discontinuity in clinicians' care or nursing home residents was associated with the increased risk of ACS hospitalizations and increased risk of ED visits related to ACS conditions, in addition to 8% higher total quarterly healthcare costs. And these findings are consistent with previous studies of the effects of clinician discontinuity in settings other than nursing homes. Discontinuity in clinician care may lead to worse outcomes among nursing home residents through several mechanisms. For example, there can be clinicians' lack of familiarity with a patient, or there can be disruptions in the flow of the clinical information when provider changes. It is also possible that discontinuity in clinicians may interact with other forms of practice that were designed to promote care continuity, such as team-based care, and they could have a differential impact on the outcomes of nursing home residents. And we thought it is also possible that as physician groups increase in size generally in the healthcare settings, they're likely to cross-cover each other's patients, resulting in the increased discontinuity among individual providers. And also we thought decreasing reimbursement rates for services, especially delivered in nursing homes, may also lead to clinicians moving to other practice settings. Because clinician continuity necessitates a greater presence of clinicians in nursing homes over time. So removing disincentivizing factors like decreased reimbursement rates may lead to residents receiving more consistent care from clinicians. Our study has limitations. First, causal inference cannot be made from these estimates because we looked at them cross-sectionally, and we did not examine the variability in the timing of changes in clinician care. But for example, if clinician changes at the beginning of the second year, that's more likely to affect the patient's outcomes compared to the change that happened at the end of the second year. So future studies could look into this topic further, but addressing these aspects, I think. And so in conclusion, discontinuity in clinician care may lead to worse outcomes among nursing home residents, and with more evidence from the related studies, including ours, CMS may consider including continuity in clinician care as a quality outcomes for nursing homes. And I've included appendix slides for the results from the sensitivity checks at the end of this slide. And with this, I would like to end my presentation. Thank you for your attention. Please ask any questions if you have. Yes.
Thank you. This is really interesting.
Thank you.
So my initial questions are, I was thinking, did you look at all about place of service delivery and whether that, this effect varies based on, whether the service was provided in the nursing home versus in a,
Yeah. So as I great question, and that was the motivation why I did this study actually. And as I briefly mentioned at the very beginning, there are relatively rich evidence, in terms of discontinuity of care among community dwelling residents and inpatient at the hospital, inpatient patients, but it was less likely to present evidence regarding nursing home residents. So
Okay.
I wanted to really focus on nursing home for this study. Maybe I think it'll be also interesting to do some kind of a meta-analysis, systematic review, comprehensively for all other settings.
Or I guess I meant for nursing home residents. Do nursing home residents only receive care within the nursing home?
Oh, yeah.
Oh,
They are long-stay nursing home residents.
Oh, okay.
So they they don't leave the facility.
Okay, then that takes care of that. I was just thinking of, assisted living, they,
Oh,
go
yes.
out, and so I was thinking, well, maybe they leave. But no, that makes sense. And then I had another question, anyway, I just,
I actually have a question.
Okay, go.
So, great job, Juliet. This is fabulous. Love seeing you present. I had a question about just in thinking about the effects from COVID. I know that a lot of folks, like, communication wasn't great with their provider during COVID, and maybe there was increased discontinuity in care there. So I was just wondering, sort of in thinking about present day, sort of quote unquote post-COVID, what this, like, has it gotten worse? Possibly better? I don't know.
That's a very great future study idea, James. Yeah, our data is like currently this data is covering up to 2019. So like fortunately before like a serious COVID pandemic. So yeah, I think there has been like huge change, like even systematic change going through the COVID pandemic period. And I actually don't know like how it really changed the dynamics regarding this discontinuity and patient outcomes, but I would really like to look into that if I obtain the data.
Curious about what your thoughts were. Thank you.
Thank you.
All right.
Oh, you had another question?
Oh, my other question was, and this may be, I'm not sure to what extent this is an issue in nursing homes, but are there teaching nursing homes? Like, are there teaching settings that are associated with like an academic health center or something of that sort? Because I was just thinking, like, if there are practices that are associated there, you would think that there would be more turnover, but a lot of continuity because of the nature of the system itself.
Yeah, that's a great question. And I think in general, officially, I don't think like, for example, CMS publicly have a system that trains those like continuously giving cares in nursing homes for the staff. But I don't know if it's like, for example, there are so many nursing homes that were governed by a large healthcare system. And I don't know if that healthcare system has that kind of training things, ongoing training stuff. Like for example, whether or not Genesis offers for their nursing home staff any kind of that. It's interesting because yesterday we had another session that was really focusing on nursing home environment, and we talked about organizations should do something like this, like educating those staff, and also we researchers should go their conferences and should represent our findings so that they could like really refer to when they design their care management system or something.
Yeah.
Thank you.